every morning things get gooder and gooder. Can't tell you how much I appreciate you all being here. Because what happens as we talk with each other, our stories come out. And as the stories come out, the consistency in our stories becomes clearer. And we are encouraged more and more to tell our story. Because your story really is my story, but I don't know it until I hear from you. You also realize, I know, that the folks at the mic are not the only experts up in here. That you have as much to share as they do. And what we're really doing is introducing you to a new family member. That's what we're doing. So as the notion of family expands, then what we realize is we're really all family. Yes. And as we study and learn more about the powerful men who were in that so-called study, then we find that we're not only connected biologically, but we're connected spiritually. And that connection is everlasting. So what we want to do today is continue the journey. That's what we're going to do today. And for those who weren't here, you may recall that we started off with a powerful keynote speaker and responded, and I saw in your face and heard in your voices, well, he was good. They ain't gonna get no better than that. But then when we had the second keynote and responded, you looked surprised because it was good. And then some of you said, man, but he ain't gonna get no better than that. And then we went and had a conversation with Attorney Gray. And then he declared, it ain't gonna get no better than that. Attorney Gray brought not only the professional expertise, but he brought the passion and wisdom from a long struggle that he continues. And for those of you who don't know it, a couple of years ago, Attorney was 85. So I don't know how old he is right now. But he's still practicing full time, and what he taught me as I watched him about planning, next generation planning, cessation planning. And he's got that big old building. If you ever seen the Gray Law Center, it's a huge building. It's probably the biggest building in Tuskegee. Much too big for him. So he built it with the vision of the next generation of great lawyers. And I know some of them, and I know there's one granddaughter in law school. And by the way, she's a TU alum, just so you know. So he's planning, and that's what we're doing. We're planning for tomorrow, but we're planning in the now. Because when tomorrow gets here, what will it be? It'll be now. And I see that planning, and the most powerful example is Kimberly Carr. She's the most powerful example of planning. And a seat was placed in her at Morehouse School of Medicine as a young MPH student. And now she's still young, but she's a doctoral student. But the planning was then. They brought her here. And then she said, I'm a descendant family member. She may not even own it. But as soon as she found out, she was gone. And you saw when she was with us last night, she's planning too. She got 2 little babies. One in the army, and what they call knee baby. Y'all, I know. See, okay, happening now. But that's planning. That's planning at several different levels. And remember yesterday when I shared that description of health, I talked about physical, social, psychological, and spiritual. We're operating on all those levels. And we may not necessarily say them consciously, but we're operating on all those levels. So we're planning. And we planned this morning very thoughtfully. Very thoughtfully. So I want you to also just be pleased with yourself, because in 6 years ago, 7 years ago, the audience didn't include the descendant family members. I watched. Y'all came for the celebration, as they called it then, a celebration. And a colleague told me, it ain't no celebration, it's a commemoration. And so we changed the name. And so I watched that event evolve into this event. And it's really evolved because of you all. And what is important in the planning is that we were planning, the Biological Center was planning in the beginning. We were planning everything, inviting y'all, whatever. And now y'all are planning and inviting us. That's the transition. And when you invite us, we show up. And you heard how apologetic Attorney was. Well, whatever the reason it didn't get the invitation, or he didn't, whatever. He was very apologetic, and he made it clear. If he'd have seen it, he'd have showed up. And so next time, copy me, and I'll make sure that he knows. And I'm sure if he knows, he'll show up. So this morning, we're going to continue this story. And we have some storytellers that will share their perspective. And again, you all, yesterday you heard me turn it over to Dr. Hodge. But really what happens is he turns it over to me, and then I turn it back. So I'm going to turn it back. Dr. Hodge.
Good morning, family.
Good morning.
Good morning, family.
Good morning.
Assalamu alaikum. Peace and shalom. I like to cover as many people as I can. We are so excited for yet another day.
Yes.
You know, I'm always excited. I'm always excited. One of these days, when I get a chance, I'll tell you how I got the name David. My mama named me David. That's why the doctor thing is not major for me. And I listen to students, respect thing. But they call me David because that's what my mama named me. She named me David because she was in pain, and a nurse gave her the Bible, and she read Psalms 27, the Lord is my light and my salvation, whom should I fear? She said, who wrote that? I said, David wrote it. She called me David. So that's why I love my name. And so I'm excited with so many things. This week started off with Dr. Kunjufu and one of my former students, Dr. Nathaniel Holmes, they did such a beautiful job. And yesterday, I've just been sailing around. And then this afternoon, we have Dr. Rosetta Ball. She's a hero of ours. And Dr. Michael Cook, he's a brother. He's my brother. When you see him, we don't look like that different mama, but that's my brother. But today, this morning, I met family again. Dr. Jordan's. when you hear her accent, it'll sound familiar. Because that's my sister there. We're going from the same place. No different place. Same situation, the same school. No, sorry, she went to a different school. She went to the Catholic school because there's some other issues they were talking about. I went to the public school. I'm a product of public school education. But we're just so excited for the call here. Dr. Warren speaks about I told you I call him the sage. He's a sage and a seer. You know, some days I call him man of God, prophet of God, all kind of religious language, because he sees things sometimes before we see things. What he said yesterday was extremely truthful in terms of the xenotransplantation. I was ready to publish. Yeah, let's ride. Let him come here and we tell him what we got to say. He said, no. He said, you young fella. We got to go slow. We got to go slow on some of these things. So I said, okay, let's see what happens, and it's amazing how it turns. Let me say this before I turn it over to our moderator. There's an ethical philosophy called utilitarianism, and we all heard of it. You may not realize it's called basically the greatest good for the greatest number of people. So it's kind of the kind of thing that you have in the majority rules. But the problem with the utilitarianism foundation is that they're initially on a misguided interpretation of the benefits of that argument is that there must be sacrifice. So, especially to the descendant family, there's scapegoating going on. When you read the literature, have you read the literature? You know, where it says stuff like, well, a good that came out of the study. And for those of us who have the lived experience, we like, I just stopped because I almost cussed. Almost cussed.
You got to explain.
There seems to be no good experience. For some wise philosophers, you know what we need is a maximum principle, where you have maximum benefits while at the same time minimization of pain. There was no minimization of pain. But to the extent that we can show up, all of this that we're doing is in fact, as Dr. Walker said, always the healing. The minimization of pain comes with the healing that not just the descendants, but we all go through, because this pain is family pain. It's filial pain. It's generational pain. It's pain of connection. So now we're going to continue the journey with what comes next. And today we have with us our moderator, Courtney Peavy. When she first came, she's an intern in our office from the communication department. So when she first came, I thought we were doing internship till I noticed, well, your name looks familiar. You're the black honors program? She said, yes. And she said something, Dr. Warren. She said, Dr. I'm a hard worker. I said, that's a lie people tell you. Let's see how that works out. She just runs this, you know I run. And she's one of my runners. I haven't been to the library for a while because she does take care of all of that stuff. But I have research stuff to do. I can't be running back and forth. She does all of that stuff, bring it to me. So this is Miss Courtney Peavy, one of our bioethics honor students. And you will be able to tell from yourself that she has energy and she's a hard worker. She did not lie. She told the truth.
And she got your fear
Good morning. Thank you for that introduction, Dr. Hodge. I'm literally a runner, y'all. I don't have a car. So I'm on the foot. But nonetheless, I present to you the first speaker of today. I apologize if I'm not easily understood. I'm getting over congestion. But Dr. Carl V. Hill serves as the director of the NIA Office of Special Populations. Dr. Hill comes to NIA from the University Sugar National Institute of Child Health and Human Development, where he was a contract office's technical representative with the National Children's Study after serving as health scientist administrator for the Extramural Associates Research Development Award. in the NICHD Division of Special Populations. Before NICHD, Dr. Hill was an HSA with the National Center for Minority Health and Health Disparities, now known as the National Institute of Minority Health and Health Disparities. He is current co-chair of the HHS Interagency Committee on Health and Health Disparity, on Health and Health Disparities, and co-chair of the TRIMS NIH American Indian, Native American, Alaska Native Special Interest Group. Dr. Hill was a member of the inaugural class of the Master of Public Health program at Morehouse School of Medicine in Atlanta, Georgia. He later joined the charter class of the Centers of Disease Control and Prevention, Public Health Prevention Service, where he worked on the CDC's 1997 Youth Risk Behavior Survey, helped to establish the Center for Bioethics and Research in Healthcare at Tuskegee University, and implemented a local version of the YRBS in Harris County, Texas. I present to you Dr. Hill. Sorry.
All right. Peace and good morning.
Good morning.
All right, it's an excellent opportunity to come home, you know, and as Dr. Warren mentioned, to be around family, you know, and to see friends and to just turn that corner into Tuskegee University just gives me chills when it's at Booker T. Washington Avenue, you know, and I just remember the many times doing that, and I think about all of the hope, you know, that's here with the students, the faculty, everyone, you know, beginning to take off. It's just a powerful experience, I think, to be here. And I'm you know, just thankful to have the opportunity, and thankful for all of you for coming out to this very important conference. Couldn't start this without thanking Dr. Warren for everything, you know. Because, you know, Dr. Warren was talking a little bit about planning, you know, and many of us here in the room are products of a plan that he put in place, you know, and continues to put in place. So this conference, this movement, this momentum, and the people that are here have all been touched by the vision of Dr. Warren, and I'm extremely grateful for that. So thanks for having me here. I wanted to talk a little bit about my journey, to tell you my story, and that was a theme also that Dr. Warren mentioned. Let's see if I can figure out how to move the slides here. But you know, my journey, I think is interesting in that it has you know, started and linked into a few places that all of us have probably been at one time or another. As my moderator, tell me your name again. As Courtney did such a great job of introducing me. I finished college at Morehouse College in Atlanta, Georgia, and started the Master in Public Health program at Morehouse School of Medicine, where I trained with my brother, Dr. Kevin Williams, who's been here all week. And you know, as we were training and learning the foundations of public health, we had a chance to work in the CDC Office of Minority Health, where Dr. Warren was the director, right? And you know, I won't tell the PERT chart story today. I won't tell it, but needless to say, we learned how to plan activity, plan a project, execute it, and evaluate all at the same time. Okay. So we got some foundational training from Dr. Warren, and you know, through that we were able to finish the MPH program, and I was, as Courtney mentioned, in the Public Health Prevention Service, where I had a 6-month assignment here at Tuskegee, where I worked with Dr. Walter Sapp, Dr. Benjamin, Dr. Bill Jenkins, Dr. Payton, Brian Lindsay, and conceptualizing, you know, what a Center for Bioethics would look like here at Tuskegee. That was we were part of the planning team that you know, kind of, you know, left off from the presidential apology. So Others have taken the momentum and created this beautiful structure. We were, the original group kind of coming down to lay a framework, if you will, and to be here to see the beautiful sign outside, the building, the wonderful faces of the people here in this room that are here to commemorate, not celebrate, but to commemorate and to rigorously discuss ethics issues and how they relate to medicine and public health. I think it's just so encouraging. So this is, again, coming home, 360 degrees, full circle, and I'm excited to be here. After that opportunity, I went on to the University of Michigan School of Public Health, where I earned a Ph.D. in public health. And today I'm going to talk a little bit about some perspectives that I consider in terms of ethical principles for some of the work that I do in stimulating health disparities research there at NIH. So during my time at NIH, as Courtney mentioned, I was with the Center for Minority Health and Health Disparities. I've worked with the Institute of Child Health and Human Development, and now I'm with the National Institute on Aging, okay? And NIH's primary function, among many, is to develop funding opportunities so that researchers, people here at Tuskegee, Morehouse School of Medicine, and Michigan, can compete and receive, these resources for training and research. So those of us there that are really committed to health disparities, we're always taking the time out to be sure that those opportunities are plentiful and that they're developed in the right way. So I'm going to talk a little bit about some of the ethics issues that have developed from those opportunities. I like to think that these opportunities to think about ethics issues operate at a couple of levels, right? So there's the operational level where there are quite a few NIH institutes. So how do the institutes work together to stimulate and create health disparities opportunities? There's the procedural, so actually implementing the research. I think there's some ethical questions and issues that we might consider. And then the impact and the outcomes of the research, right? And I think as we think about the Tuskegee Syphilis study, the impact and the outcomes are what's most discussed, and I'll extend some of that discussion a bit more. And I'm operating from a definition that ethics is a philosophical discipline, right, pertaining to notions of kind of good and bad, right and wrong, kind of about moral life and community. Bioethics, if you will allow me, is the application of ethics to public health, medicine, and healthcare. So ethicists and bioethicists ask relevant questions more than provide sure and certain answers, right? So it's the question that we want to be sure that people understand as they debate what the ethical direction might be. So just a little background about NIH. We like to think that we are the biomedical premier enterprise in the world. I think others may not agree with that, but again, we're looking to fund and support rigorous training and health disparities research. So that science is in the pursuit of fundamental knowledge. I think fundamental is very important here, about the nature and behavior of living systems. And then I think most importantly to those of us that are really interested in public health is the application of that knowledge to extend healthy life and reduce the burdens of illness and disability, right? So, fundamental knowledge, not only proximal understanding, but, fundamental knowledge of living systems, and then applying that knowledge to protecting health through lessening the burdens of illness and disability. So we think about, we think a little bit about living systems. You have to think about how we're organized, or we organize ourselves into groups. So there are important systems, I think, in society that health disparities researchers in general might consider. Race, ethnicity, right? So I've laid that here out in this slide. Socioeconomic population, so your access to important resources is very important in terms of living in this society. Geography, so living in a rural or urban context is so important. For those of us that are interested in elder care or aging research, there's a consideration of a disability status, right? So being sure that we understand how people are living those lives. And then, more recently at NIH, there's been a consideration of sex and gender minorities as an identity for fully understanding the living systems and the way people organize their lives in society. And there may be many more. There's so many more. But these are the ones that are priority and kind of guide the way that we think about research at NIH. And if you think about those systems, we know that from the aging perspective, just right off the bat, there are differences in how long people live, right? And there's so many factors that could be important for understanding that. If you look at this graph here that shows life expectancy comparing whites and blacks, there was an increase because of advances in public health and medicine from 1900 to 1950, and generally there's been an increase for whites and blacks, but not at the same rate, right? So if you look at black men, kind of lagging behind in terms of life expectancy, it's important to understand what are some of the factors that enhance life expectancy for everyone, but restrict for some others, right? So that at the crux, I think that is a very interesting issue for health disparities in aging research. We also take a look at multimorbidity, right? So multimorbidity is the situation of having multiple chronic conditions over your life course, which makes it hard to treat one when you have to consider the other. So we're talking about an issue related to quality of life, right? So multimorbidity is a very important outcome for aging research. And here, I'm taking a look at racial ethnic groups that include blacks, whites, and Asian populations. We see that blacks are affected by multimorbidity along the life course in the 30s and 40s and 50s at that window in midlife. And then as the aging trajectory continues on, there's some changes. So the point here is that it's important to understand the mechanisms that underlie these disparities, right? So could it only be biological? Is it cultural? Is social factors important? And so there's so many ways to think about how these differences or disparities, if you will, are important. So we need to consider the co-occurrence of conditions at all ages. So you think about the health of older adults, you have to also think about the health of those same adults at midlife, right? Because we're thinking about this from a life course perspective. And then when you think about interventions, ways to address this that are appropriate, accessible, and affordable, so that we can really hone in and focus in on specific factors and populations that are most important. So to conduct all of this, I think, which I think is the most important research, health disparities research, right, is considering those that are most disproportionately affected, right? So this is, in my mind, in terms of public health, biomedical, and health-related research, why else would you do it if you didn't want to understand who was disproportionately affected, right? So to lead that charge at NIH is our National Institute on Minority Health and Health Disparities. So there are quite a few institutes. I won't go into every one of them at NIH. I'm there at the National Institute on Aging. I highlighted that because we're the best. So we work very closely with the Institute on Minority Health and Health Disparities to think a bit about how to stimulate this type of research, right? And I'll get into some of the issues that I think are very important. The National Institute on Minority Health and Health Disparities was created by legislation, by law, by Congress, that requires reporting for each one of those boxes. So as I go through quickly, there's the National Cancer Institute. I mentioned that I had worked with the Institute on Child Health and Human Development. There's an Eye Institute, the Institute on Nursing Research. So there's a broad, array of different enterprises that are tasked with thinking about health-related research, thinking about biomedical research, and they are, should be thinking very rigorously about health disparities research. So NIMHD does this coordinating, not because they're just, we're simply interested in it. There's a law in place that requires these institutes and centers to have a plan for health disparities research. So that plan must include all activities within an annual budget, and there must be an evaluation that should be done. And so this is very important to the NIH enterprise, and NIMHD has been tasked with doing that. But here are some important, I think, questions from an ethical perspective, and that is, what is the impact of NIMHD on other IC innovation and participation? So I mentioned each one of those boxes is tasked with, developing funding opportunities for health disparities research. One area that we see that's quite interesting is this notion that if there's an Institute on Minority Health and Health Disparities, let them do that, right? So we won't do as much of it, right? So what is the operational part of this that could promote, right? Could motivate or maybe prohibit the other ICs, the Cancer Institute, the Child Health and Human Development, how they innovate in this area that is so important. Also, how does a newer IC, and NIMHD is a newer enterprise at NIH, how do they take on the role of coordinating health disparities at NIH, right? So Dr. Warren and I have worked closely at NIMHD together, and there's the prospect of this particular institute giving money, resources to the other institute so they could stimulate this activity. But then again, we go back to point one. They just depend on the NIMHD to provide resources, and they don't have any skin in the game, if you will, for being active in this area. So that's another operations question that I think has been very interesting since my time at NIH. And then third is one that I've really considered in my time there, and that is, how does a diversity lens, a focus on racial ethnic populations, lower socioeconomic groups, how does that impact these operations, right? So again, there is what I think health disparities research is the most important research that you could conduct. But then the populations are underrepresented minorities and people that live in lower socioeconomic circumstances. Not as popular. So what is the element of structural discrimination or racism at this particular scientific enterprise that prohibits NIMHD or health disparities research from advancing? It's an ethical question. I don't have an answer, but it's something that we should consider. Moving to the second lens, if you've been following the news at all, and this doesn't hit the front page of the Washington Post, but if you're in this world, you know that the National Institute on Aging has been receiving additional funding to stimulate Alzheimer's disease research, right? So I've been discussing health disparities research, the most important research. There's public will, I think, is very important for older adults and aging populations. What do we know about Alzheimer's disease, right? What are the factors? What causes Alzheimer's disease? So our institute receives an annual appropriation from Congress. For the past 3 years, including 2018, it just came out last week, we received an additional $400 million on top of our appropriation to stimulate research and training for Alzheimer's disease. So that's very important because that gives us resources to really innovate and stimulate some activity in this area. And when you think about Alzheimer's disease and health disparities, we have supported some research that shows that participants in a search study with the highest SES, so socioeconomic status means those that have the most income, the most resources, the most education, the most income, or the occupation is ranked ranked the highest. those that had the highest SES showed the probability of staying survival-free of dementia. And Alzheimer's disease is a type of dementia, okay? So there is something going on in society where you have access to important resources, you're able to avoid the circumstance of developing Alzheimer's disease. Important question, I think, for health disparities research and its additional resources we have for stimulating activity. Also, we fund recent research from Maeda and her colleagues there at the University of California, Los Angeles, UCLA. They took a look at Kaiser Permanente members with Kaiser Permanente with health insurance, so people that are part of this health insurance plan. And the incidence rate of dementia, again, including Alzheimer's disease, by race and ethnicity shows that African Americans are disproportionately affected with dementia and Alzheimer's disease, right? So we've got the funding, we've got the opportunity. There are some important questions as they relate to health disparities with SES and race and ethnicity that should be priority. Do you agree?
Yes.
Okay, all right, I'll just make sure you're with me. But in that regard, just 2016, 2 years ago, there were a couple of investigators that took a look at all of the studies that we have been funding with that additional $400 million per year, the clinical trials. And if African Americans who experience a lower SES circumstance in many geographical locations, you would think that this particular population would be priority for research. But in reality, African Americans are least likely to be enrolled or participate in Alzheimer's disease research. So you have the circumstance of the population, African Americans that are disproportionately affected, being least likely to participate or be enrolled, depending on your lens, in these studies. And one interpretation of that from many of our principal investigators that we fund is that African Americans, Latinos, other underrepresented groups are hard to reach. No, they're not hard. We're not hard to reach. You know what we are. You just may not want to go there to conduct the outreach and engagement, but we're not hard to reach. Absolutely. Absolutely. There are ways to engage communities that we've been using community-based participatory research for years. But in this particular new momentum, this new area of stimulating Alzheimer's disease research in health disparities populations, this idea of engaging and participating is just catching on. But we have the circumstance, again, of ethics is an ethical area to consider of populations that are disproportionately affected not being enrolled in the studies. So you have the circumstance of potentially developing therapies, interventions, policies for addressing Alzheimer's disease that don't include the folks that are disproportionately affected. If anyone's interested in this area as an investigator, we just released a funding opportunity because my office and others have been, this is a major issue for us. So we just released a funding opportunity that will provide millions of dollars to investigators to examine diversity, recruitment, and retention in aging research, right? And so our challenge is to make sure that not only we get good applications, but they're investigators that can put together a nice application. We need investigators that understand how it really works, right? So making rigorous plans and providing best practices and lessons learned for recruiting and retaining underrepresented populations in Alzheimer's disease research is very important. So take a look at it. It just came out last week. We're looking ideas and people who know what they're doing, who have experience in working with communities. And just like my friend said, take one of us with you, right, who can know how to evaluate that idea.
And cuss. Use your cuss.
That's right.
That's right.
That's right.
That's what he's here recruiting.
That's right. That's right. That's right. So, as I kind of round out in terms of the procedural recruitment and retention, and I think questions, my lens is to provide questions to think about. What are the factors that lead the most disproportionately affected to be least likely to be enrolled? Is that more, is that we don't want to participate? We don't trust researchers? Or no one ever knocked on the door?
You just read it.
I just read it. Okay, and also, what are the ethical and cultural factors for investigators to consider when for recruitment and retention? So again, the things that we know to be important, we've got to consider. And also, I think it's important is we're going to have this rush of applications and people are going to be coming in. How do we avoid exploitation? Right? So we're all raising our hands saying this is a big issue. Sometimes the wrong folks get their hands on the resources and we feel more exploited by being a part than if we were never a part at all. So how do we do this the right way? Third, and I have 5 minutes here, is health disparities research itself, right? So we've got a pretty broad definition of health disparities. Dr. Warren mentioned this, environmental, sociocultural, behavioral, biological, and I wish I could include spiritual, but it's the federal government. They wouldn't allow that. But that is the way that we are connected, and that those are factors that are so important in the way that we think about the pathways, if you will, that create and sustain health disparities research. I like to think that health disparities has been informed by some of the great philosophers and ethicists that have come to help us think about group differences. Max Weber focused in on morals and values, it's kind of ways of life among people, placing the blame on the individual. Things you do will help you protect health, or the things you do will put you at risk. Karl Marx, don't be afraid, another philosopher addressed, thought about this a bit differently, right? He said, hey, there's class differences. So I put up a slide a minute ago about dementia and socioeconomic standing. Karl Marx would think about this a little differently. Access to important resources and access to structures would be the way that he would think about health disparities. And then I think race and ethnicity in the United States, and the sociologist and philosopher W.E.B. Du Bois got right on it when he said it's the stress of life here in the United States. So something about being African American and seeing others advance in a higher socioeconomic status. So the stress of life, to be a poor man is hard, but to be poor and black in the land of dollars is the very bottom of hardship. Take a look at this data that makes W.E.B. Du Bois's point. So you think about heart disease, the #1 reason for death in the United States, and education. The relationship is the more education, the more protective factor you should have, right? From a socioeconomic status perspective. Let me say that again. So the more education you have, the more likely it is that you might have a good paying job, and that may provide health insurance that could potentially protect your health. Do we agree?
Right.
Okay. So when we compare blacks and whites in heart disease, a ratio is the difference between those two populations. The ratio increases So among those with the most education, the gap in heart disease is largest. What is that about? Anybody get idea?
Yes.
Stress.
The stress.
The stress of getting educated, the stress of the job, the stress of social mobility. All these are very important. I think that makes the point that.
And it's also the factor that you're told that if you get the education, you get the job, but then you always get the job after you get the education.
That's right. That's right. And that's right. So taking a look at the person who may not look like you with the same education,
Right.
living on one side of the lake, and you know, we're living the life that we live. So at NIA, we have developed a framework. I'll go through this really quickly. I think my time is running out, but it's the 1 minute. It's the assessment of thinking about levels of analysis. And so it's so important, I think, from these philosophers. You know, Max Weber focused in on, I think, proximate factors, people's health behaviors. If you smoke cigarettes, if you drink alcohol, then it's your fault that you developed the health profile that you had. We like to think that it's so important to think about pathways, right? So behavior in context. Culture matters here. Social factors matter here. Residential segregation, access to important resources in the way that Karl Marx mentioned. It's so important to think about this from a pathway perspective. So in terms of ethics questions that I have considered in my work, how much should we support policies and interventions that focus solely on proximate factors, like these health behaviors or access to health care? Right, by the time you get to the doctor, you've already lived a life of dealing with stress and all types of activity that's so important. So how much should we focus only on proximate factors? As a government person who's thinking about taxpayer dollars, it costs more to think rigorously about fundamental factors, upstream determinants, changing policy. That's very important. So, how do you grapple with the cost of an intervention that that have a really high price tag, but may be more effective in reducing or addressing the disparity? And then what we've also come up against is this idea of a comparison group for research, right? So disparities is taking a look at differences, but do we always need to have a comparison group in the research study to fund it? Is it okay to include studies of only Latino population to fully understand what some of the determinants are? And is that health disparities research? I tend to think that it is. So as I conclude, the NIH structure and its NIMHD will play an important role in supporting its health disparity strategic plan. We'll see how that plays out. It's going to be so important. Recruitment and retention of priority and underrepresented populations must be guided by ethical principles and practices and avoid exploitation. So important. And then I think health disparities research should explore pathways. Again, not focusing only on these proximal factors. And how do they link to social factors so that we can think about policy change and intervention that are fundamental and make sustainable change. Okay. So I'm looking forward to the discussion. This is me. Email me at any time. I do respond, set up a time to talk. I'm on Twitter. And I thank you for having me here.
Very insightful presentation, Dr. I will present to you the respondent, Dr. Catherine Georges. She is professor and chair of the Department of Nursing at Union College and the Graduate Center of the City University of New York. She is president of the National Black Nurses Foundation. Previously, she too was a staff nurse, team leader, supervisor and District Manager of the Visiting Nurse Service of New York. She serves on the board of Black Women's Health Study and F.A.A.N Incorporated. She earned her undergraduate degree from the Seton Hall University College of Nursing, her master's in nursing from New York University, and a doctoral degree in educational leadership and policy studies at the University of Vermont. She resides in Bronx, New York.
I will stand here and decide and talk as Dr. Hodge puts in my USB, which is just a few slides that guide me in talking. Otherwise, I'll be here going over the time and you'll be jumping up. But thanks, Dr. Warren, for inviting me. Dr. Warren and I go way back. We don't say the number of years, but we all belong to many organizations over time, and we've been in the trenches over the years, long before some of you in the room were born. You know, so some of you have been his students, and over time, and Dr. Warren and I have seen some of the changes and some of the words that begun to change as we got into what needs to be done in this country, what should be the role of those of us who are health professionals and who have been quite clear that something's wrong and things need to be changed. So my journey, as Dr. Hodge told you, and I don't have no accent, I live in New York, everybody sounds like me. But I come from the St. Thomas, West Virgin Islands, and my journey's been a long one. It's been a long one, and it's been a good one. I still enjoy what I do, and so I still work. But in the last, this is 2018, so in the last 8 years, I have taken another track, where as I begun to evolve, I don't call it aging, it's evolution. As I begun to evolve, at NYU we call ourselves evolutionary emergence. You know, so as I began to emerge, I knew that there was something else that needed to be done. There have been lots of things that we could do, and I've been doing in my professional organization, but I got involved with AARP. Now I'm going to ask all of you who belong to AARP, but we do take members 50 plus. And when I listened to Dr. Hill, I said, he's got the data, he's got the science. We're the advocates to make sure something moves from the bench to what needs to happen in community. That's what we do in AARP. And one of the things as we talk about what needs to be done for people who are aging in this country, not growing old, there's a difference, who are aging, who are going through the process, the cellular changes, the behavioral differences, our interactions with different groups. We need to have some folks who will advocate for what's right, because it's right. And that's what they have to do. And so when you think of the evolution of AARP, which started 60 years ago, one white woman who worked in South Central California in Los Angeles, who felt that there was an ethical issue operating in this country where people who had worked all their lives, had given to this country, had prepared the leaders who were emerging at that time 60 years ago, could not live on the monies that they had gotten for all the years that they had worked. This was before Medicare. People had no money, no health insurance. And as I talked to groups such as this and all over the country, I said, not much has changed in 60 years. We've got more vocal, we've got the data, we've got the science, we've got the organizations, but we are still seeing people who every day are really having an issue. This is the issue. 10,000 people are turning 65 every day. You know, Dr. Hill, all the funded projects, etc., that you're talking about, I looked up all of them. And all the work on Alzheimer's and all the genetics, etc., have to address this. Because these are the people, 10,000 turning 65 every day. And the boomers are 78 million strong. Now our membership in AARP is only 38 million. And because we got 14% to African American, we are the largest African American organization in the country. I just thought I'd say that. But the issue that Dr. Hill talked about, you know, about the multiple chronic problems that older people have, did not start at age 65. It started at 20, 25. The natural history of the disease is now, you know, is now obvious because they did not have appropriate interventions along the way. The disparities, the access, the thing that you didn't say, the blatant racism and institutionalized, I could say it, I don't work for NIH. The blatant racism that's operant in all the systems that have prevented older people from getting the kind of care they need. So now they're at the point in their lives where they've got these chronic conditions. And yes, they are consuming more services. They have to. Their bones are fine. They can't get in and out of a car as easy as they used to. They've always been underrepresented in clinical trials if you come from a racial and ethnic minority group. For all the reasons that Dr. Hill gave that people say they can't find them. They just don't. They need GPS, you know, so they put out black neighborhood and then take it there. You know, but one of the other things as we age that we were saying now, you know, maybe we need to have at this point in our life a more active role in making healthcare decisions. We're finding that out. We've got offices in every state, including Alabama. I'll meet them next week. But and Puerto Rico and the United States Virgin Islands. So people are saying, you know what? We've worked so hard, we're at this stage in our life, we now want to have an active role. So some people are seeking out these clinical trials. They're saying, I want to know how he could live longer than me, or why he's getting this, maybe I should be part of it. Not as much as we would like, Dr. Hill, but people are beginning to move towards that, and we're seeing that. But there's some ethical principles we need to address, and I think you alluded and you talked about some of them. And as we see and we talk to folks in our communities across the country, people want to have autonomy. I ain't at this stage in my life and nobody be telling me what to do. You know, and the right to determine what they want. And so all this great science, I don't knock science, I firmly believe in it because science informs policy. And so what we see is the right to say, yes or no, I do not wish to have that. Tell me, you know, there's one of the things that, you know, Dr. Warren, all of you who work at CDC and all for the feds, you know about all this issue about these low-value services that we have, these medical services and treatments and so forth. And everybody's always writing, including us in AARP. If you go on our public policy website, you'll see we raise questions about the value of many of these tests that we know have low, you know, data. I mean, we don't know that they work. But for some people, that's all they got. And we can't take that away from some of the vulnerable populations because they won't have any testing, Dr. Saunders, you know, as an epidemiologist, they won't have anything if we remove. So that's an ethical issue that's being raised. Should we or shouldn't we? Should we remove and say no longer will we pay for these, quote, low value, you know, testing, etc.? Because if you take it away, some people will have nothing. So they won't even have the hint that they may be having a problem that's arising. So the beneficence is, you know, we got to do good for somebody. And it's not nonsense about this good coming out of all these horrible experiments is not what I'm talking about and not we talk about in AARP. We're talking about good because it's good for the people, not coming out of some foolish, experiment that didn't work. And the whole issue of veracity, the transparency, one of the reasons people want to know up front, what the hell is this damn study supposed to be doing? They don't want you to tell them after the fact, oh, by the way, we forgot to. So I know that there's all the rules. There are rules and they're telling all the rules. So there's a difference. And so just because you're an older adult does not mean that you've lost all your cognitive abilities. I'm 74 and I still think I can think. You talked about, all the aspects and your levels of analysis, and we in ARP are honing in on the social determinants, particularly for the vulnerable populations that we see, and we're looking for all the kinds of data that will emerge from the studies that you fund. One that we think that people are missing is this whole issue around food insecurity. And the fact that so many of our adults, our older adults, particularly our Black and Hispanic populations, not so much Asian Pacific Islanders, but Black and Hispanics, are left without having sufficient food. So all the nutrients, all the changes that are occurring biologically may be directly related to the food insecurity, and then, of course, changes in cognitive ability. There's smoking, some of our folks, I ain't gonna ask anybody in here, this is the South, this is the but, about smoking, but we know what smoking has done and the destruction it caused. From the studies done out of heart, lung, and blood, out of allergies and infectious disease, about all the lung issues and all the changes in, and therefore brain changes. So, if you couple all of this with all the things that your researchers are doing, we're not looking cause effect, we're not doing the science. We're looking at it from a policy perspective and using big data and analyzing what our folks in our public policy institutes have found in the relationships. The other big thing is homelessness. People think that older people in this country are fine, that they live someplace. Well, a lot of them don't. They live from daughter to maybe cousin's child and this family member. And so homelessness is played a big issue. And you may live in a house and still be homeless. And then the other issue is isolation. As so many of our population ages, they're left alone. They're isolated. And some of the studies have emerged out of the National Institutes of Mental Health in looking at isolation, loneliness, and depression. And we say one of the things we found in work that AARP has funded is the cost to this country and older adults who have been so isolated and become depressed. And so for those of you who are direct practitioners, they're always in the emergency room. Ain't got nobody else to call. 911, it becomes their friend. And what the cost is to the system, and how do we break that cycle? So, and I know my time is coming fast, but one of the things that we say is, therefore, we're going to disrupt aging in this country. I think I've disrupted it already. I'm still alive. And so one of the things that we think will be helpful, and as we look at what you're doing and your researchers are doing, particularly around the dementia, we've got, that's one of our thrusts, is looking at dementia. Now we're not going to go out and do the research. We're going to support those who may be, and looking for what that means then to help the populations that we provide, not provide, but that are our members. So as we're disrupting aging, we're going to disrupt this racial and ethnic disparities. And the first place that did it was New York. We launched our Disrupting Racial and Ethnic Disparities back in January. And we are not going to allow what's happening in New York, where our folks who are older are now having to leave the city because they can't afford the rents. I mean, you get a little closet about this big, and that's $2,500 a month. And we're not talking about folks who are receiving public assistance. We're not talking about folks who are on Medicaid. We're talking about people who have been working people in this country and have paid into the system. So we're going to disrupt that, and we're going to make sure that these systems that have consistently discriminated against older people and now older racial and ethnic groups. You have seen the work and the studies that are emerging. I don't know if it came out of your division or someplace else in the feds, but what AARP has is that we are finding that older blacks are being placed in nursing homes that have the lowest quality. They're the least staffed, they have no registered nurses, or they got one covering the whole building of 100 patients. And so we're going to stop it because we think it's time for us. 5 minutes, okay. The other thing we have is is looking at brain health. AARP is the secretariat for the Global Brain Health Initiative. And they never have a meeting when they go to Europe that I could go. They always want to have it in Washington. But anyway, but it's a global brain health. And one of the things that we do in AARP, that through our AARP services, we encourage our members to buy those kinds of software that keeps their brain stimulated. So I got one. I try to do it in the New York Times at possible. I think that should keep anybody's brains moving. But it's really because it is so critical what's happening with brain health. The whole dementia that AARP has partnered. One of the groups that we're partnering is National Black Nurses. I didn't have anything to do with that. Even though I used to be the president, that I know. But you know that we're partnering because of all the data that's coming out from your institutes about African Americans and the increasing dementia, not just Alzheimer's, but increasing dementia at early ages. We're seeing 60s. The other people that they are emerging are Latinas more than anybody else because of their diabetes. So we're looking to see what else is coming out that we should be involved with from a policy perspective to drive policy to discontinue it. And then a whole enterprise-wise and throughout all of our offices and our state offices is this whole issue around healthy aging. Get up and walk. Dr. Hodge told me you walked last night. I was in my bed. I was not walking. But he's young. But how do we get folks as they age to do the things so that when you find that in some small demonstration projects we have across the country in cooperation and collaboration with other groups, people are walking. We've got older people who are helping younger second and third graders to read so that they're keeping themselves active. And as I said, the Drive to End Hunger, I got 1 minute. Drive to End Hunger, which again tries to cut through the food insecurity that you will see as your folks begin to do their research. I'm looking to see how this issue of the type 2 diabetes and this increase in dementia is going to go. I know you guys are finding some of it, and so is the National Institutes for whoever funds diabetes. And then decreasing isolation and loneliness. If you sit home and you have no stimulation, one of your levels of analysis is environmental and behavioral. You have no one to talk to, nothing to do. You're going to sit there and your brain, you're not going to be able to I don't know, I'm not a brain scientist. I'm the policy person. But the bench is going to have to give us that kind of data. And so we look forward to all those issues and things that you can do to assist us in making sure we get to grow older in this country with dignity, independence, and purpose.
Can we take the first question, please?
Good morning.
Good morning. I'm Renee, resident physician from Harry Medical College in Nashville, Tennessee.
One second. Okay, now we're ready.
From the Harry Medical College in Nashville, Tennessee in preventive medicine. My question is, as we approach or encourage trust in ethical, legitimate research, how do we safeguard our this population or our elders against those who might seek to take advantage of them with identity theft or something like that? How do we safeguard this population?
We have a national program, and this is National Against Fraud, and that's AARP that we're doing and throughout the country. Tennessee, I know, is one of the great states that has a great state office. But one of the big issues is, you know what the feds have done. They're no longer social. If you're on Medicare, you're going to get a new card. The new card will no longer have your social security number on it. So that's because to prevent those kinds of things. Because when you go into trials, etc., you know, they need your social security number when people come in for identification purposes. So that's going to be gone. So they won't be able to extract stuff from medical records that may have been identifiable through social security numbers. The other thing is that throughout the states and in conjunction with other local, you know, organizations, the issues about how to safeguard your any of the papers, etc., that you may get in shredding. And this is Shred Fest month. It is. So that trying to shred as much as you can, and then just talking to people, older folks, you know, I don't like to call myself, people who are Asian, are going through the process. You know, they just think we should keep everything. And so that's one reason why they get taken. For those of us, and Dr. Hill can talk some more about it, but for those of us who are like you as a physician and encouraging your patients and or families to participate, is that they understand that it is the people who are conducting those studies are safeguarding and are required to safeguard the information. And so they're not the people that you should worry about. They're the folks who come visit your house and pick up your maid and your business that you should be concerned about. And those are the people that we need to make sure that you get rid of your stuff before they come visit. And they may not mean to harm you, but once they get the information, that's it.
And I guess just a quick add on that. You know, I've been impressed for reasons that are tough, but tribal health councils and the way that tribal communities protect their citizens and their involvement in NIH-funded research. So on one hand, participation is very low, because on another hand, the particular council is protecting their communities and wanting to be a part of studies, and if they can't be a part, then they won't participate, right? So it's finding a way to engage communities, engage our communities, if we're saying our in terms of African Americans, making sure that we have processes in place that the NIH may not think about, right? It's communities, it's people, our churches, our community-based organizations, to protect our folks, to be sure that we understand what they're signing up for. I think
Dr. Hill, the things that you was talking about this morning, I might have some help for you. In Syracuse, New York, they have a few programs going on like that now in some of the senior buildings, and it's funded through upstate New York, and it's done through the hospital. And they go to the senior buildings, they come, They have classes, they take their blood pressure, check their heart, and different things, but they never have one of the things that you're talking about now. So it'd be a good chance that you might get something going on there with them at Upstate Hospital.
Absolutely. Thank you for that suggestion. You know, with this funding opportunity announcement, again, we're looking for investigators, you know, we call researchers, to really give us some help in terms of recruiting and retaining underrepresented population into these clinical trials in the right way, which is related to the first question. So, you know, we want principal investigators, again, that can not only put together a sleek application, you know, and get it into the electronic system and all the things that, you know, investigators at big universities can do, but we want investigators that are committed and passionate to doing this the right way. So thank you for that suggestion.
Good morning. My name is Kimberly Carr, fourth-year integrated biosciences Ph.D. student here at Tuskegee. I have two questions. One, how do you join AARP? It's not for me, clearly. But do you have any information or, I guess, membership applications with you?
No, it's all online. www.aarp.org.
Okay. And the other question is, I'm learning that there is a lack or decrease of social marketing for, I guess, clinical trials for participation across all lifespans. How are we going to increase that? Because again, all of these issues are important, but again, as much as we see so many commercials, and then I hear radio getting more, 20% more listeners on radio, how are we recruiting actively with a marketing campaign for that? Because I'm learning that through these traditional methods of, you know, you send a funding announcement for the researchers, or you may go to the church, we also have to acknowledge everyone doesn't go to church or a place of worship. So I was trying to figure out or wonder how are we reaching these populations, all populations?
I think that's a good point, and that's what we would want. You know, again, people respond to this, the investigators. We want them to test methods for recruitment and retention that are novel and innovative, right? So door to door, you know, knocking on someone's door, that has a huge cost, right? So my other hat is federal employee looking to use taxpayer dollars as efficiently as possible. So how do we leverage gains in social media for you know, reaching a span of individuals that might, you know, be more cost effective than door to door? I think social media holds great promise, but then we're hearing about Facebook and these other platforms and vulnerability, going back to the first question, that it may place people. So how do we protect you know, personally identifiable information? Your health records that are not out for people to use your financial information, but also ethically recruit our folks into these clinical trials. Because again, we're developing therapies and approaches and interventions, and we're not in the study.
I just had a quick question and a comment. I support the work of the National Medical Association, and right now we're partnering with the NIH All of Us research program. And the focus, I was hoping that you two can speak to your perspectives on that, because right now what we've been doing is hosting a lot of workshop and focus groups with our physicians, NMA physicians, who largely serve African American and minority communities. So we're trying to figure out how to best engage their patient population and also what the concerns are. And of course, among the people that we've been talking to, this has been coming up. Tuskegee has been coming up as an issue. Not an issue, well, yes, as a concern. And I'm hoping that we're just trying to figure out how do we engage in the proper way, because we do want involvement of our population. If there's going to be some research or a cohort, they're trying to recruit 1 million people for a 10-year cohort to collect information about health, lifestyle, environment, all of that. So I am concerned because I do want us to have representation, but I also want to make sure that you know, our population is protected as well. So I just wanted to hear your comments about that. And I wanted to say too, if you are able to, please come to the NMA convention this year in Orlando. We're having a symposium on Sunday, August 12th, and we're hoping to have the NIH director, Francis Collins, there. We will also have a chief engagement officer, Dr. Richardson Heron, who is a Black physician, and she's heading up this initiative and trying to get us as involved as possible. So I'm hoping that all of you know that you're welcome to be there and represent your perspectives.
Well, the National Black Nurses Association is also part of that, along with the NMA. And so at our, we just had a webinar, this was last week, week before. And so it's a concern. The members of the organization raised the concern. They raised it with the people who were at our day on Capitol Hill in February. And, you know, again, asking, because communities are asking, what is the assurance that, one, we will, as you say, Dr. Hill, include it, but how are you going to make sure that our business ain't put on the street, as I like to say. But, you know, how are you going to use that? Are you going to use it for or against us? You know, I know one of the big concerns that older people have is that that the information may then prevent them or their children from getting health insurance. Because if they reveal that they've got cystic kidneys, you know, is that going to stop? You know, is that genetic? You know, is it familial? Will their children be refused, you know, insurance, health insurance later on in life? So those are some questions that we heard in one of the questioning that occurred at the day on the Hill, when people were questioning, you know, those kinds of things. So, you know, it is a concern.
Yeah, just, you know, really quickly, all of us, you know, I'm excited about the All of Us initiative because of the collaborations with businesses, right? So there's one difference. I was with the National Children's Study previously. I was going to do a case study of the children's study for, you know, ethics. There's so much there. But there's, again, this operational way that a federal agency would deal with study centers. And study centers hoping to recruit a nationally representative, generalizable population. I don't know if the All of Us initiative, I may be wrong, but I don't know if that is a goal of the All of Us. So there's a convenience sample, right? So there's two different, I think, concepts. So you're all, you know, nationally representative. You're going in to study locations, and you have to do what you can to get people from that particular geographic location. With the children's study, outreach and engagement was the most, the most expensive part of the study, right? So we're spending money, low recruitment, high use of taxpayer dollars. Put it in that perspective. So I think it's going to be interesting based on the way that the All of Us study is set up. It's going to be different, and then it's a really unique, I think, innovative collaboration with businesses that can be very helpful.
Great presentations by both of you. It's not going to stop the quick narrative I wanted to say really quick. I haven't told Dr. Hill this yet, but I was really excited when you talked about loneliness, Dr. George. My mother raised Dr. Hill as well, and his mother raised me. We've known each other since we were about 5 years old. So it didn't start at Morehouse School of Medicine, but it started at College Park. But anyway, I got a call from my mom. You speaking about loneliness. I got a call from my mom. She hasn't dated in 24 years. Her and my dad got divorced after 28 years of marriage, and he passed away in 2014. But I got a call, and she said she met a friend, and I said, okay, and this was in like October. I said, okay, you met a friend. Me and my sister, she's grandma, me and my wife go on dates, we drop her son off, and my sister does the same and gets her dates in with her husband. But you sometimes forget about the loneliness that may be there, even if you grandma, right? So I got a call again in January and said, well, we've been out on a couple of dates. And then the next call I got was, my friend is coming in from North Carolina. He wants to come down to Macon, Georgia and ask for my hand. I said, okay, Mom. So, to make a long story short, your second mom is getting married at my house July 7th. Okay, I said, you know, he spent the whole day with me. I fed him and everything. And right before he left, I said, you know, you asked me about an hour ago, could you have my mother's hand? I said, well, if you pass the marriage counseling that you're in, you can have my mom's hand. So we're having a wedding at my house July 7th. So I'm going to let you know that. Yeah, but I was fascinated when you looked at, I mean, that's a big problem. Loneliness is a huge problem. And it can't just be defined by grandmas. You know, we obviously, my mom's 71 and her fiance is 76. Right, fiance.
Aging.
I'm sorry, they're aging, yes.
They're disrupting it.
Oh, they're disrupting, exactly. It's a good point. So, you know, it's something that I think we kind of look past, and it's something that we definitely need to keep in mind. And I hope that more research looks at those kind of factors, because, you know, you can't just define, you know, how are we defining loneliness, you know? You say you have a child, and then also another part of that is, my mother has been a caregiver. You know, so how much is the caregiving impacting on people's health as well? We know that, you know, that's something to look at as well. And then another quick comment, just kind of going to another part of you all's presentation. You kind of raised the issue of gentrification in part in your presentation. That was the city that me and Carl grew up in, College Park, and also the Atlanta Metro. That was a huge issue in our elections, was affordable housing. And the fact that our seniors are getting pushed out, our pillars of the community are being pushed out of our cities. We had a good friend running for mayor. We know the person who won the mayorship. She went to FAMU with me. But that was a huge issue. And so I'm wondering, where are we with that? And I know you brought it up, so I'll let you all find time.
Well, across the country, it is an important issue, particularly in large urban areas, because the older population, we did a study in New York last year, AARP, and we talked about the disappearing Black and Hispanic middle class out of the city, out of New York City, because they could no longer afford it. So that what's happening is they're moving into other parts of the country. North Carolina seems to be one of the highest that people, at least from the north, are moving to. And it is an issue. It's an issue that then becomes a governmental issue, if you want to call it, a policy issue. And so one of the things that we have in AARP is livable communities. We've got a whole big program of livable communities and age-friendly communities. And it's the age-friendly community, it's not just an American problem. The whole issue about age-friendly communities is global. And so it's, I mean, the world is aging, you know, everybody, you know, it's a movement, we're living longer, you know, middle age is, you know, now 75. You know, so that I'm considering myself middle age. 70. But what's happening, this is happening all across the world. And so it's been driving with coalitions, collaboratives, collectives, Dr. Saunders, collective folks to have collective impact, to really begin to relook at the cities and what can be done in those cities to have the affordable housing where children can live, where a baby carriage can be pushed just like a wheelchair can be pushed. But it then requires a commitment from not just government, but from businesses, private industry, and groups such as, like here, where you can drive the policy and raise the questions about, you know, what should be done. So that's a drive across the world. And New York, our governor has just, New York is now the first and only age-friendly state. State, not just city, state. And that's now a push, and we're looking to push legislation and push policies through to keep the people that you're talking about in the cities. Because we don't want to lose their wisdom and all that they have to bring to the city. But it's going to take a while for it to happen.
Yeah, me and Carl have a friend in Harlem, and he said they're trying to rename Harlem because of the gentrification.
Well, they have renamed it because the black folks don't own it.
No, and just I was trying to catch it real quick, you know, I'm having to meet this guy. Protect. We see this in Washington, D.C., where, you know, real estate is just, you know, and it's, so place matters. I mean, I think what we lose is the context that this is people's homes. Their neighborhood is where, it's not just a house that they live in, this is a cultural place. So when people take the money, you know, I lived in Washington, D.C. in Brooklyn, neighborhood Brooklyn for many years, African American, and all of my neighbors on this particular street were older adults. All of my aunts, you know, I lived in this row house, they were all, you know, living alone. And Miss Scott, who's a great neighbor of mine, she took the money. Because people are literally knocking on your door saying, do you want to buy, can I just give you $300,000 right now for your house? You know, change your life. And, you know, she did that, moved to Virginia, and sadly, you know, she passed in a year. And I think some part of it is just being out of her home. You know, and sometimes it's not about money, it's about, you know, place matters. Place is where your family, your extended network is.
So, we have three final questions. Amy, and Dr. Summers. But mine was the first of the last. Because I was interested in Dr. George's, because of time constraints, you're moving too quickly, and there's one thing that you missed out there, and I think it's extremely important. As a matter of fact, in this conversation now, I see the importance of it, and it's the term violence, which I'd like you to say something else on. Because I'm also hearing with Kevin's question and with Carl's response, the kind of violence in gentrification. If she died in a year, we could interpret that as a violent act towards her. So what kind of nuanced violences are taking place among that population? And then from there we go to Jenny and Amy, and then Dr. Sanders. That'll be the last question.
When I had put up the violence, it was because of all the, looking at elder abuse. And it was not just the violence physical, but all that has happened, all the emotional, you know, violence that occurs with folks as they're growing older. We know about the financial stuff that happens. And you know, interesting, it's caretakers, but it's not just familial caretakers. You know, it's what has happened around, you know, as folks got older, and what are those issues? Because, you know, your daughter doesn't live near you. My daughter lives in Georgia, I live in New York. They can stay in Georgia. But, you know, what happens if your child is living someplace and you have to have a page, you know, and what happens? Those are the kinds of things, Dr. Hodge, that had to do with the violence.
So not gun violence, violence.
No, but it was all the other things around elder abuse, financial abuse, emotional.
Morning, my name is Alicia. I am a student of Master of Public Health at Morehouse School of Medicine. And my question to you, Dr. Hill, regarding Alzheimer's disease research. So have you conducted any research or the research that has already been done related to Alzheimer's, showing how to slow down the process of occurrence of Alzheimer's and the progression of the Alzheimer's disease?
Yeah, that's a good question. So again, from my perspective, $400 additional million, and there have been all types of biological kind of bench clinical studies. And I can say that we're actively funding studies. This is our third year doing that. So you would say a research project that we fund is 5 years. So we're hopeful to learn more. Dr. George has mentioned the association between vascular factors of diabetes and the development of dementia, including Alzheimer's disease. Physical activity being, one protecting kind of health behavior that has been shown some promise, but that's kind of general. That's not the finding that we're looking for in terms of, how do we understand these amyloids, plaque buildup, and amyloids in the brain. So to be continued, but there, from a health disparities perspective, we know that there's a relationship between stress, life course stress, and cognitive decline, right, among our population. So what type of stress, what are stress exasperating, conditions that may occur in a person's lifetime. And, all these are, I think, critical research questions, and that's our job, is to kind of get the resources out to the investigators that are going to do the rigorous work. We're hopeful in the next couple of years that we have more information.
Thank you so much. Yeah, I'm next. Very, very amazing presentation. And one of the reasons, so I'd like to thank both of you tremendously. And one of the reasons is because I think those of us who work in research don't always get to see how things are always implemented on the programmatic level. And the two of you just positioning yourselves, it's an excellent opportunity for the students to see. So I have a question for you. In your research, one of the data points when you show the difference between socioeconomic status and education as related to dementia, those who had higher socioeconomic status, you mentioned this, and higher education were protected. It showed that on the slide that those who had high educational status and low education were not.
Right.
Now, how does she implement that as a programmatic?
Yeah,
that's very interesting.
And I think that was an interesting finding.
Yeah.
So, low education, high socioeconomic status. What does that mean with the network that you run in? I mean, there's so many different hypotheses that you might think about, and you may say that could be a spurious conclusion based on the study sample that they use, right? So I would want to replicate that to see if that finding is durable, if you will. But I think that this relationship between research and policy is interesting. I think the relationship between public will, so with Alzheimer's disease, the Alzheimer's Association and quite a few other nonprofit, kind of corporate organizations really have pushed, made an impact where we are at a race for authority. We need the same type of push and public will for health disparities.
Very good. And then the other thing was this whole issue, we talk about comorbidity. There's also this kind of comorbidity as it relates to these social determinants all packing themselves together. So around the issue of housing, everybody kind of looks at from the perspective of the lower socioeconomic status trying to move, being forced out. But there are many elderly people that are trying to downsize, and they can't even afford to do that. Which adds loneliness and all of the other factors that we're talking about because of how they live and the stress that they have. Trying to maintain these homes that they don't need anymore because people have left them.
So they can't even afford to buy something.
That's such a good point. That's such a good point. It is. Because on this street where I live, we were in row houses that were they were joined. You shared a wall. So you saw someone every day, right? Versus living, like you said, in a home where no one comes to visit, and you may go days without anyone knocking on your door.
You can be in a neighborhood and be isolated.
That's right.
Yeah.
That's right.
The new world, and that's the way it is now.
I want to thank you all for your participation. That closes our question and answer portion of this group session. And I'll turn it back over to Dr. Warren.
And we have different opportunities to address the concerns that everybody knows. So in our research agenda, we're not trying to raise new questions. We're trying to answer questions that everybody knows. So much of our work is not surprising to anybody, but we have data to support it for those who need data. And we also know that data doesn't really drive policy. Politics drives policy. And we've been collecting data for years. Same data, same conclusions. But we need to continue to collect it. And that's why we have Dr. Hill to guide it. So it's important. What I hope you saw is not a independence or a dependence, but an interdependence. Hope you picked up interdependence. Youngblood and one of the emerging you see what I'm saying? A young scholar who's been through the rigor. You know what I'm saying? He just didn't go through the rigor. We put him through. We put him through, so we know he's worthy. We care less about his degrees per se, but we've been through it. He's been through, so we know he's worthy. But then we had to bring one of the, say it again, emerging, evolutionary emergence to validate him, to say he's okay. You know what I'm saying? Dr. Georgia said he's okay. If you pick that up, he's okay. And until she said he was okay, I knew he was okay, but until she said he was okay, y'all didn't know he was okay. And hear me now, and he took you through his journey to let you know he's been with us. He spent more time talking about getting to Michigan than being at Michigan. You picked it up, but he talked about getting there. You see, and then Dr. Williams took him someplace else. I know your mama. There's some subtleties that's going on up in here. And if you're not on it, you'll miss it. You're not alert. Yes, stay woke. Because I know your mama. And then a little later on, if you watch Dr. Hill's eyes, who's coming up in here talking about barriers? No, y'all ain't getting it. He was serious. And then Dr. Williams said, well, let me give you the date, so you can be sure and get there before that date. There's some stuff going on that y'all have to pay attention, because you may miss it. But what you see is our roles. Where do we fit?
Well, our roles came past you.
Say what?
Yeah, our roles came past you. They were letting you know, hey.
Oh yeah. No, and see, I needed permission. And I waited. And then my mother, who's not physically here, and my wife reminded me, don't say, so two things about a woman you don't mention, their age and they wait. But when my good friend Dr. Georgia said she was 74, then it let you know that she is, well, I have to say, yes ma'am. I'm 72, but I'm still saying yes ma'am. You hear me now? And I'm gonna take this thing because it's my minute. I mean, I'm working all the time I want to. And y'all took some of my time yesterday with that phone. That same fire alarm been going every day for the last every day for the last. So I know it was a false alarm. I can tell you. Because they get a sense that the police up in there. Anyway. On a more serious note, they're raising the question about our involvement in both the research and the results of what happens from that research. And the reluctance to engage in research is related to not so much the U.S. Public Health Service syphilis study, but the continuation of the same violations.
Yes.
The continuation of the same violations. But who can raise the ethical question with the moral authority better than the National Center for Bioethics and Research at Tuskegee? No place else. I've been some places. I've been on faculty at some places. Not to brag per se, but for y'all to know. I was a student at Harvard. Everybody thinks Harvard is all that. Harvard is all that. Because people believe it's all that.
That's right.
And then I joined the faculty at Harvard and tried to raise the questions that we needed to have answers for. Same intellect, same preparation, but ain't nobody listening. I raised those same questions at CDC. Ain't nobody listening. I raised the same questions at Tuskegee. Everybody listening. Not because of me, same questions, but because of place. Because of place. So I'm saying that for you all to appreciate this place and how that translates into the work that is important to do. We, at this place, were funded by Eli Lilly and Company to answer the question that we raised of enhancing African American participation in clinical trials and in human subject research. And we got funded to answer that question. Only could have happened at this place. And so we have some of those answers, but they really don't want all the answers. So we've started enough and demonstrated enough that we can answer the questions, but it's only the first part of the question we've answered. And let me just say what that first question was. We asked leadership, we asked us, why don't African Americans participate in clinical trials? And we asked 35 of the leadership in higher education, health professions education, in the faith community, and in civic society. And we define civic society as NAACP and Urban League. And that's how we did that. And what it comes down to is a question not of trust, but of trustworthiness. Different issue. Not trust, but trustworthiness. We have trusted long enough, and those who we have trusted have not proven themselves to be trustworthy. So don't ask me to trust you if you have not earned it. So we got data. that will be in the literature soon about how to establish trustworthiness. So it's more to come, but I'm stopping to pause because they're raising the empirical question of trustworthiness. And so repeat that language as you engage in what you do. When somebody says, trust me, say, have you proven yourself trustworthy? It shifts the burden of responsibility from us, that is those who they're soliciting trust from, to those who are asking for trust. And it goes beyond race and ethnicity, sex and gender, location and income. That's important, but it's not enough. So that's an important ingredient to begin to establish. And I'll also just say in passing, is that I've worked with both of these colleagues, as you can tell. And so we know what needs to be done, and we know how to do it. And we just need more to join us in doing that. Because there's trustworthiness, you've heard that. I asked Dr. Georges to come about a month ago. She shifted everything around. Not because she wasn't busy, but because I asked her. And then she made that clear, because you asked me. And so what I'm saying, that trustworthiness takes time to establish. So NIH, the rest of y'all, have to engage the time to establish trustworthiness. Trustworthiness is more important than trust. Now, so y'all asked me to go through this again. We always wanted to thank folks who come to Tuskegee. And we give our speakers something to remember Tuskegee by. And for our keynoter, we prepared or purchased a pen desk set. So when you put it on your desk, people will know where you got it from. It says Tuskegee University National Center for Violence and Research in Healthcare. And that's the formal gift. That's the one that you can really get into and put what you want on it. So I'm going to give this to you. The most important one. In 2015, we celebrated the 100th year of Booker T. Washington's death, and we really celebrated his life. And we engaged in a whole year of, every month we had something different going on. Folks heard about it and they called and wanted to participate literally. We weren't including everybody, just the folks that we thought were authentic and really wanted to. CDC called and asked, and we agreed to establish and clarify what Negro History Month was, but more importantly, where Minority Health Month came from. They didn't acknowledge, they knew that Booker T established Negro History Month in 1915, collecting the same data and having the same conclusions. So a colleague, Reverend Leonard, who's Tuskegee alum and also lives here, created a coin. It has Booker T's picture on it and his mugshot and the date, and it talks about that year. And so we had several developed, and what we don't sell them. They're not for sale. And we only give them to people who are worthy as a sample, not a sample, but as evidence that you've been here and done something for us. So we have one of these for each of you. And you won't find it any place. And y'all tell them, if somebody shows up with the coin that had not been here, what do you know? Thank you so much, Dr.